I want to thank everybody for attending this WebEx. It's going to be a CUA accredited session on new immuno-oncology combinations for untreated metastatic kidney cancer, an emerging standard of care. So this is going to be a web series WebEx, and we have a live audience. Thank you all for coming. And it's also being broadcast live as well. It'll be archived on the CUA website, and you can go to www.cua.org webseries, en./webseries to look at this. And let's press this, I guess. And again, it's accredited by the CUA, the Voice of Urology in Canada. Looking at the advanced RCC treatment landscape again, looking at new IO agents in first line. It's accredited for Section 1 credits by the Royal College of Physicians and Surgeons of Canada, and it's been approved by the CUA CPD committee. So the objectives are to look at new data regarding IO first-line treatments for metastatic RCC, to gain insights into sequencing in metastatic RCC and the future roles for TKI-based treatments, and apply case-based responses to IO and TKI combinations. My name is Anil Kapoor. I work at McMaster University in Hamilton, and I'd like to introduce Dr. Scott North. For those that don't know, Dr. North received his MD degree from the University of Ottawa in 1994, many years ago. Yes. But now he still looks very young. Completed his training in internal medicine and medical oncology at the University of Alberta. He has a master's in health professions education from the University of Illinois in Chicago, and he focuses just on GU medical oncology. He's currently a professor in the Department of Oncology at the University of Alberta and the director of the Division of Medical Oncology and section chief of medical oncology. So certainly a very well qualified medical oncologist to give this talk, and he is an active participant in many clinical trials and over 100 peer-reviewed publications. So we're honored to have you as part of the scientific program committee, Dr. North, and it's going to be a great program that we developed. These are our disclosures for the meeting today. And the program was developed by an educational grant from Roche to the CUA, and Roche develops, licenses, and distributes a product, atezolizumab, and so that we'll be talking about this product during the course of this program. So without further ado, we'll have Dr. Scott North start his talk. Thank you.
Thank you very much. Thanks very much for everyone who's attending both online and in person. It's really a pleasure for me to be able to dive into a little bit more of the data for you with regards to some of the new immunotherapy treatments for advanced kidney cancer. And I really do believe that this will become an emerging standard of care as we go forward. To set the background of why we're talking about this, we've had some experience with immunotherapy for some time now, especially in the second and third beyond line settings, looking at nivolumab as an example in clear cell carcinoma. And the pivotal trial of Checkmate 025 demonstrated there was a survival benefit in patients who were pretreated with TKI therapy, where nivolumab was superior to everolimus with an improvement in OS of 25 months versus about 20 months with everolimus. We also had seen that there were improvements in response rates and an improvement in progression-free survival, but no difference in progression-free survival. And that really established monotherapy nivolumab in the post-TKI setting as a standard of care that we were using in the clinic. And just to show you this, this is the Checkmate 25 study design where patients who were previously treated with metastatic clear cell carcinoma were stratified by a number of variables, including where they were in the world, their risk factors, and the number of prior therapies. So this was not just purely second-line therapy. And they were therefore afterwards randomized to either nivolumab at the standard dose of 3 milligrams per kilogram every 2 weeks or everolimus. And the end point of overall survival was met. And we saw that with the nivolumab group, there was a median survival, as I mentioned, of 25 months versus 19.6 with a nice separation of the curves. So this was the pivotal trial that we used in registration across the world, including Canada, to have access to monotherapy nivolumab, but in a pre-treated patient population. And these patients now in Canada can receive nivo after 1 or 2 lines of prior TKI therapy. But of course, when you have something that works well in that line of therapy, the idea in oncology is we move everything more proximally in the disease trajectory. And the treatment paradigm is now really evolving to put these IO agents into the first-line setting. And there are a number of trials that have either been completed or are underway. And what I'll talk about today is some of the data, but keep in mind this is a very dynamic and fluid field. And there are a lot of trials that are underway, not yet having presented data or are actively recruiting. And the two trials that I really want to focus on, because they may influence what we do in the near future, are the CheckMate 214 trial, which looked at the combination of ipilimumab and nivolumab in the untreated patient population, and the Emotion 151 study of atezolizumab with bevacizumab, both of which compared themselves to standard sunitinib. But as I mentioned, there are a lot of trials underway, and we'll show you some of those towards the latter part of the talk. To start off with, let's look at the CheckMate 214 study, and this was presented at the ESMO Congress. It was an efficacy and safety study of the ipi-nivo combination versus sunitinib in treatment-naive patients, and these patients were stratified by their IMDC risk category and their PD-L1 expression. The background of this is that nivolumab is a PD-1 inhibitor, and as I just mentioned, based upon the CheckMate 25 study, it's been approved for patients who have already been treated with tyrosine kinase inhibition. And the ipi-nivo combination had been shown in a phase 1b trial, the CheckMate 016 study, to have a manageable safety profile and toxicity profile, but some very impressive response rate data at 40% response rate, with some of those responses being very durable and a median progression-free survival of 7.7 months. And in a very heavily pretreated patient population, this is quite an impressive response rate as well as overall survival rate of 67% alive at 2 years. Therefore, there was a scientific rationale to want to move that type of a combination strategy into the treatment-naive setting and compare it against sunitinib, which was the standard of care. The study design is, as you see here, treatment-naive patients. These are first-line metastatic renal cell carcinoma with a clear cell histology. They had to have adequate performance status, and there needed to be tissue testing for PD-L1 status. The patients didn't have to be PD-L1 positive to get on the study, but we needed to know what the status was because that was part of the analysis. And they were stratified by their IMDC risk score, and we know that this is a validated prognostic score that is used in the era of targeted therapy that has 6 clinical and biochemical variables to it, so that you can put patients into categories of risk. If they have no factors, they're good risk. 1 or 2 factors, they're intermediate, or 3 to 6 factors, they're poor risk. So they stratify patients by their risk category, and then their geographic location. And they were then randomized to the experimental arm, where they received 4 doses of the ipilimumab at 1 mg per kg every 3 weeks, in combination with nivolumab, and then following those 4 doses of combination therapy, they were given nivolumab maintenance. And the control arm is the standard schedule of sunitinib of 50 milligrams a day for 4 weeks on, 2 weeks off, with the standard dose modifications as per the product monograph, which is how all of these trials have to be done, and we can argue about whether or not that's how we give sunitinib in the real world. But because the product monograph dictates the terms of that, we have to follow that in terms of what we do on the clinical trials. So no dose individualization of sunitinib is allowed on these clinical trials. The study had co-primary endpoints, and primarily what we were interested in is the intermediate and poor risk patient population. And the co-primary endpoints were response rate, progression-free survival by an independent review committee, and OS. And in order to have all of those co-primary endpoints, we only have so much statistical power that we can play with. So the alpha of 0.05, which we traditionally think of as being statistically significant, has to be split amongst those endpoints. The majority of that power was spent on overall survival because that was the most clinically important endpoint. And then a smaller amount was given towards response rates and progression-free survival. So it's important to remember that because some of the traditional p-values that show up in the graphs and the numerics that follow may look to your eye to be statistically significant, but they won't actually be statistically significant because of what the rigor of the test was, because we've split the p across a number of variables. There are secondary and exploratory endpoints as well, specifically in the intention to treat population, and this includes the good risk. So remember, the primary endpoint here is really focusing on intermediate and poor risk, and the intention to treat is the global population of patients, which also includes our good risk patients. And there we were also looking at response rate, PFS, and OS. As well, of course, we're looking for safety and adverse events. There are a series of exploratory endpoints also, and probably the one that's of most interest to us is how did the favorable risk group do individually as a small cohort of people, and also everyone is always interested in how the patients respond to the immunotherapy based upon their PD-L1 status. The baseline characteristics for the cohort of intermediate and poor risk patients are shown here, and it's nicely balanced. You've got people who are approximately in their early 60s, a predominantly male population. Now, you're going to see, of course, 0% here of IMDC good risk because they're specifically not in this cohort. These are only intermediate and poor risk. And the majority of the patients are in that intermediate category, which is what we see in day-to-day practice. Relatively well split from geographic regions, and based upon the assay used in the Checkmate study, we have approximately a quarter of our patient population being PD-L1 positive or overexpressors, and therefore 3/4 of the population are underexpressors or negative. This just expands upon that to add in the intention to treat population, so it's now adding in the rest of the patients who are good risk. So now you can see the entire cohort of the patients, which really does reflect what we normally see in day-to-day practice. About a quarter of people are good risk, a little more than half are intermediate, and then we've got that 15 to 20% who are poor risk. The number of PD-L1 positive versus negative still held up, and it's about a quarter again overall who are PD-L1 positive. If we look at what happened to the patients over the course of the trial, you'll see that about 77 versus 82% of patients have discontinued their study treatment at the time of this analysis and presentation. And there are more people in the sunitinib arm overall who have discontinued because of disease progression, but slightly more on the combination IO therapy who have discontinued because of toxicity. However, really, adverse events overall were well tolerated and managed by the investigators. Average duration of therapy, about 8 months, and the dose intensity of the therapy for the Immuno patient population was quite good. They got all 4 doses of Ipi for the most part and about 14 doses of the Nivo. And once you took a look at the patients who received sunitinib, they received about 30 milligrams of sunitinib overall. Keep in mind, these were fixed dose reductions. If you went toxic at 50, you had to go down to 37.5. Response rate and duration of response is shown here. This is one of our co-primary endpoints for the intermediate and poor risk patient population. And the important thing to point out, I believe, here from my perspective is you see, number one, that there is a higher response rate in this population for the combination IO, 42% responding versus 27. However, this is what strikes my eye all the time, and it's the complete responses, because if we believe that the shift in how we treat patients might actually yield these durable long-term responses and, dare we say, a cure, similar to what we've seen in other diseases like melanoma, the people that really are that tail of the curve are the ones who've had the complete responses. And we're seeing significantly more complete responses with the combination IO therapy as compared to sunitinib. And of those patients who do respond, so these numbers down here are the ones that respond, you can see that the people who maintain the response for a longer period of time is greater in the IO. So you get more robust responses that tend to be more durable. This is PFS. Now the PFS for the intermediate and poor risk patient population looks to be numerically about 3 months longer in the Ipi-Nivo combination. However, because of this p-value being split across the endpoints, this is actually not statistically significant, whereas on the previous slide with the response rates, it was statistically significant. So we have interesting preliminary look at what PFS is like. And this has certainly been seen in other IO studies where PFS doesn't seem to correlate with other endpoints, such as survival. And this is the overall survival, which is one of our co-primary endpoints, highly statistically significant, that the median survival for sunitinib is 26 months, and for the ipi-nivo combination, it's not been reached. And again, the curves are separating nicely, and they're staying separate, and therefore, with a statistically significant p-value here, we have a survival benefit in the intermediate and poor-risk patient population in favor of the combination IO therapy. Now we add in the rest of the population, the intention to treat population, and that now adds on the good risk patients. And you can see that this benefit in terms of response rates and progression-free survival diminishes. We now have a difference of 7% in absolute terms between the two response rates, and the PFSs look the same. And this is the first hint that when we took a look at one of our exploratory endpoints, which was just looking at the favorable risk patient population, we actually don't see any longer that there's a benefit being driven by giving immunotherapy to that patient group. In fact, the sunitinib arm would have a higher overall response rate of 52% versus 29%, and a higher progression-free survival of 25 months versus 15.3. Again, this is exploratory. It wasn't the primary endpoint of the study, but it certainly does tell us that it appears as though we are seeing the benefit be driven by the intermediate and the poor risk patient population. So now if we want to also look at the PD-L1 expression, because this is sort of the bane of all of our existence, about what do you do with PD-L1, how is it helpful, is it prognostic, is it predictive? And the take home for me here is, number one, it really isn't predictive, because there are people who are PD-L1 negative who respond quite well. In our patient cohort of intermediate and poor risk patients who are still PD-L1 negative, we have 7% complete responses versus 1% with sunitinib. If they're positive for PD-L1, you can see quite a nice 16% CR rate, which we've never seen robust data like that before. If you add in the intention to treat analysis, the numbers drop a little bit because we're adding in that good risk patient population who doesn't seem to drive as much benefit from this. But overall, what this says to us is that PD-L1 is prognostic. If you have PD-L1 overexpression, you're probably going to have a better chance of getting something out of combination therapy. But if you're negative, it doesn't mean it doesn't work. And therefore, we would not be of the opinion at this point in time that you could use this as a predictive factor that could help you delineate who could or could not receive treatment with combination immunotherapy. Graphically, if we look at PFS, if you're PD-L1 negative, there really is no separation of the curves, but if you're PD-L1 positive, there's a very nice separation of the curves with regards to your PFS for the intermediate poor risk patient population. That's helpful for me, I think, if I knew the PD-L1 status in counseling people, what to expect. But as I just mentioned, you wouldn't want to use this as a discriminating factor at this point to say, I'm not going to offer you treatment with IO. Of course, we're always concerned about toxicity. And with even the standard of care with TKIs, we know that there's toxicity from therapy. Not surprising, in a study like this, there are almost every patient has something. The high-grade toxicities are about 50% in ipi-nivo versus 63% in sunitinib, but none of them are strikingly coming out on the top of the page here on the slide as being particularly scary, with the understanding that we see hypertension with TKIs. That is pretty much understood and it can be managed. A few people had to actually discontinue their therapy because of toxicity. Of course, with IO, we're interested in immune-related adverse events, and the grade 3 to 4 toxicities, I think, are the ones that keep us up at night, wondering if what we've done and if we've done the right thing. And unfortunately, again, these are low in their frequency. However, it is important to note that 60% of patients treated with combination therapy did require corticosteroids. And so this is going to be either IV or oral corticosteroids. And so we do need to be cognizant of the fact that these people need to be monitored. And this has certainly been something that, has always been taught in people learning about IO, that you need to jump on these toxicities, be aware of them, and early use of immunosuppression helps to prevent you from going to a higher grade. But it is noteworthy that 60% did have toxicity. So the summary conclusions from the presentation was that in that group of intermediate and poor risk patients, that the trial definitely demonstrated an improvement in OS. And the combination Immuno versus sunitinib shows that there is a significant improvement in overall survival. And there's also an improvement in response rate, but the PFS is not statistically significant. However, in that exploratory analysis, it doesn't seem like the good risk patient population is necessarily deriving the same benefit. And PD-L1 positive patients demonstrate a higher benefit than negative, but we're not at the point where we would say that if you're PD-L1 negative, you should never have a chance to receive this drug combination. Now, the other data that's come out recently that's getting a lot of play and a lot of talk is the Emotion 151 study, which was a randomized phase 3 trial of atezolizumab and bevacizumab versus sunitinib, again in a treatment-naive patient population. The background behind this is that the combination of bevacizumab and interferon is approved for use in first-line therapy, but not in Canada. It's approved in the US and it's approved in Europe. And there is single-agent activity with bevacizumab in RCC. Atezo has also been shown to have some activity in smaller phase 1 and 2 trials, and because of the concept of targeting a combination therapy that has both an immunotherapy component and a VEGF targeting component, it made sense to try to combine this together and see whether or not this combination strategy would be superior to sunitinib, which once again is the standard arm that's being compared to. So this was a phase 3 trial of atezo-bev versus sunitinib. The primary endpoint here was progression-free survival, and it was progression-free survival as assessed by the investigator in the PD-L1 positive population, which is defined by a different assay in this trial compared to the Roche or the BMS study with Immuno. There are a series of secondary endpoints such as PFS and the intent to treat, so that includes the PD-L1 negative patient population, and there's also endpoints looking at overall survival as well as independent radiology confirmation of PFS. The trial eligibility are quite similar, treatment naive or metastatic RCC. There had to be adequate performance status and tissue available once again for PD-L1 testing. We didn't have to have PD-L1 positivity to get on the study, but there needed to be tissue available to do that testing. And the stratification this time was not by the IMDC risk score, but rather by the MSKCC. And while they're similar, they're not completely identical. And then, of course, stratified by the presence or absence of the liver metastasis and what your PD-L1 status was. Randomized 1-to-1 to the combination of atezo-bev every 3 weeks, or the same sunitinib schedule as per product monograph and as was used in the prior trial. They enrolled 915 patients, and 40% of this cohort is PD-L1 positive. So if you'll remember, the prior study was about 25, 26%. This is 40%. And this is part of the challenge that we face in interpreting data because these assays are different from company to company, study to study, agent to agent. You would imagine that, or you would think that these patients are somewhat similar, and so the PD-L1 positivity should be similar, but it just goes to show it depends on, are you looking at archived tissue, fresh tissue, what are you biopsying, and there's a whole host of questions about PD-L1 status. The primary analysis was PFS in that PD-L1 positive subgroup, and it was triggered after they had a number of events by September of 2017. And at that point in time, they did an analysis of overall survival. So it's understood that the overall survival analysis is premature and it needs to mature with further time, but it was done at the same time as the PFS look. And similarly, they split their alpha between most of it for PFS in that PD-L1 positive population and a smaller component for overall survival. The patient populations are quite similar. Again, these are right around early 60s, predominantly male patients. About 20% of patients overall have liver metastases, and the vast majority have had a prior nephrectomy. Most of these patients had predominantly clear cell histology. What is slightly different is the sarcomatoid component. So you could have sarcomatoid features and get on the trial, and that typically is an adverse prognostic feature. Again, if the primary cohort is of interest is PD-L1 positive, we assume they're all PD-L1 positive, and for the intention to treat overall, when you add everybody together, 40% of the whole cohort of 900 patients was PD-L1 positive. And they were relatively equally split across the board in terms of those risk categories, again, the majority being of the intermediate risk category and about a fifth of people being good risk. This is the primary endpoint, one of the co-primary endpoints, which was PFS in the PD-L1 patients who were positive as judged by the investigators. And obviously, the investigators are not blinded to what the patients were receiving. The PFS here is improved from 7.7 months with sunitinib to 11.2 with atezo-bev, and this is statistically significant. So this does meet its primary endpoint, or one of its co-primary endpoints of PFS. When you look at the intention to treat population, this now adds in the other 60% of patients who are PD-L1 negative, and the absolute difference in PFS remains at about 3 months. In terms of objective response rate, similar to what we saw previously with the other trial, you do find that there is a slightly higher response rate with the combination immunotherapy, VEGF-targeted therapy versus sunitinib, and you are still seeing some quite significant numbers of complete responders, 9% versus 4% in sunitinib. The one thing that I would note is that this is a 9% CR in a PD-L1 positive population. In the prior study, it was a 16% CR in a PD-L1 positive population. Different assays, different studies, and I know it's not fair to do cross-trial comparisons, but I did want to make note of that. The other thing that I would make note of is that in the intent to treat population, which includes the PD-L1 negative, you're still seeing that 5% CR rate. Once again, we haven't been able to tease out who should or shouldn't receive therapy with immunotherapy based upon their PD-L1 status. And then just looking at this as a secondary endpoint of objective response rate, one can see again the graphic representation of the response rate, and of those people that do respond, some of those responses are quite durable. The one point that I think is also worth remembering, and this is true of the prior data as well with the combination Ipi-Nivo, not everybody responds, and there's a lot of hype about immunotherapy, and we see a lot of patients coming in and they want it badly. But progressive disease as the best response is still seen in a fifth of patients or more. And so we need to be cognizant of the fact that we have to still be selecting patients properly, and that some of the other drugs in our arsenal still work. And if we are going to be looking at upfront immunotherapy, we have to be aware of the fact that we have to be prepared to stop it and go on to something else before we lose that window of opportunity. And sometimes we are victims of our own success, and that the hype that's out there about these agents sometimes makes people shy away from being given anything other than immunotherapy. One of the secondary endpoints of this study was to look at the PFS and the overall response rate by the independent review committee. And what was noted here was that overall the trend was similar in that the response rates in the PFS were higher in the groups receiving the atezo-bev compared to the sunitinib, but the magnitude of that difference between the two groups was not quite as significant when looked at by an independent review. So as an example, PFS is 8.9 months versus 7.2 months, and overall this does not fall into being statistically significant when you look at all of the data on the table. And then although this is a secondary endpoint, there has been some discussion as to why this would be a discordant between the investigator reporting their PFS and response rate results versus an independent review committee. Now, both investigator and the independent review committees were blinded to the PD-L1 status, but certainly the investigators were not blinded to the treatment allocation because they knew what their patients were receiving. That being said, the trend is still there that there's more response in the patients receiving the VEGF IO therapy. On subgroup analysis, it's always hard when you're starting to break people down into multiple subgroups to actually see on a forest plot any one particular category always be on the side of statistical significance, because you lose the power to be able to detect that. But the bottom line would be that there's no clinical or other factor that would predict that you shouldn't have a chance to respond to the atezo-bev. Whether you have liver metastases, nephrectomized or not, sarcomatoid features or not, whatever category of risk, and whether you look at MSKCC or IMDC. this is a bit in contradistinction to the prior study where the good risk patients didn't seem to benefit, and here we're not seeing any sense that the good risk patients might not benefit from this combination. And if we look in the intention to treat population, where now we include people who are PD-L1 negative, and then to look at all of the PD-L1 status, you can see clearly there's this gradation that the more positive you are, the more you benefit, but everybody's still on the line on the side of positive results with atezo-bev compared to sunitinib. So it's, again, telling us prognostic, but not necessarily predictive. Now, the overall survival data, as I mentioned, is immature, so we don't expect to see anything as of yet. We do see that the blue line on top of atezo-bev survival is slightly higher than sunitinib, but again, not statistically significant. Only about 29% of patients at this point have had an OS event, and therefore this is not statistically significant, and neither group has reached their median OS. And that's true whether or not you look at the intention to treat or the PD-L1 positive or the whole population. Perhaps in the PD-L1 patient population, you would like to believe that we're going to start to see something here, but time will tell. The data are immature, and we have to wait and see. From the perspective of safety, it is clear here, again, that patients do really well with therapy. And certainly from experience with people who have participated in both of these trials, the atezo-bev combination is quite well tolerated and quite easy to administer. You have about 40% versus 54% having some grade 3-4 toxicity, which means that you have to do something most likely. And few patients have to really have discontinuation of their study intervention because they were having significant toxicity. The toxicities are predictable. So with sunitinib, you saw the typical things that you would see: diarrhea, the hand-foot syndrome, hypertension, fatigue, etc., with few people in the darker red having the high-grade toxicity. And on the immunotherapy, it was, again, worrying about looking at diarrhea. There was some hypertension. There's fatigue noted with these agents, not surprisingly with the hypertension or proteinuria because it's bevacizumab, so that's within the toxicity profile of the agent. But the dark blue, which represents the high-grade toxicities, other than the hypertension, which is known and expected and treatable, there really wasn't much here. And the AEs of special interest, which are really related to either the really IA-related, immune-related adverse events, such as the glandular dysfunction, LFT abnormalities, colitis, etc., very low rates of grade 3-4. And this patient population, only 16% of individuals need corticosteroids, which is different than the prior study where 60% need corticosteroids. Therefore, perhaps there's going to be some separation that comes out as we learn more about this data in patient selection as to who might tolerate one combination versus another. And the quality of life was certainly maintained. This is a well-tolerated combination, and more people have difficulty with sunitinib interfering with their quality of life than they did with the atezo-bev. So the study conclusions of the authors were that it met its co-primary endpoint of PFS in the PD-L1 patient cohort that was positive, and that the responses are certainly encouraging, and they acknowledge that overall survival is immature at this point, and we need to continue to watch. It was very much a well-tolerated combination, few high-grade adverse events, and should be considered as an option for therapy. And certainly when it was discussed, and I think Dr. Kapoor is going to show us some of the results or some of the discussion from the Canadian Kidney Cancer Forum and the consensus, there was some discussion about whether we should put this on as an option. There was some concern that maybe we needed a little bit more maturity of the data, but certainly given how well tolerated it is and how encouraging it is, we want to at least be mindful of the fact that as this matures and as we may get access to these agents in the future, we need to be mindful that this is quite an active combination. Just to compare and contrast just a couple of the key differences in those two trials I presented. The Motion 151 with the atezo-bev did include patients with sarcomatoid pathology, which is a nasty subtype of pathology. Checkmate 214 was clear cell component. Basically, these were all treatment naive, although Checkmate 214 allowed patients with adjuvant or neoadjuvant therapy as long as it had been more than 6 months. But they're a minor component because there's no real approved adjuvant or neoadjuvant therapy. there's a relatively good balance between the risk categories, and I've already pointed out that the MSKCC and the IMDC are not identical, but they're relatively similar. This, I think, is the one thing that most of us are going to question, interpretation of data. You know, you've got a 40% PD-L1 positive rate on one study and a 24% on the other. Is that assay related? Is that what was biopsied? Is that a function of how the patients were chosen? How are we going to look at that in the real world, where a lot of centers are not checking PD-L1 status for anything? And one of the concerns that we have is that we don't want necessarily to be limited in our PD-L1 status, for example, with the Immuno, and we don't want to be boxed into a corner and be told who can and can't get it based on PD-L1 status. And just as I mentioned, this is the beginning of the tsunami of data with combination therapies. And there's a lot coming down the line looking at IO-IO or IO-VEGF-TKI combination. The Javelin trial of axitinib plus avelumab compared to sunitinib has completed its recruitment, and we're waiting. We've got an axitinib pembrolizumab data set that we'll be looking at with interest. There's now looking at triplet therapy with nivo, cabo, and nivolumab cabozantinib or nivolumab ipi cabo. So that'll be an interesting toxicity challenge, although it's interesting that the triplet therapy in the initial phase 1 seems better tolerated than the doublet. The CLEAR study has just started to pick up steam in Canada. This is a trial with lenvatinib, Len-Eve versus Len-Pembro versus the standard of sunitinib. Once again, looking at combination IO and VEGF-TKI. And then we've also got dendritic cell vaccine therapy out there as well. So it's a very, very busy space at this point in time, and how we are going to put all of that data together in the future will be very interesting. And with that, I'm going to turn it over to Dr. for a case.
That was an excellent overview, and well done to go over those IO studies. I think it's a lot of excitement coming up for patients, and lots of great data coming up shortly with those other studies as well. So I'm going to present a clinical case, a patient of mine, and we'll have some interaction with the audience, so I'll have to have you all stay awake. Dr. Zariba, I'm talking looking at you. We have some people in the audience as well online, and so I see Dr. Ben Chu is online, as well as Dr. Abara and a few others, and Dagan Finch, and so we'll have, hopefully they can ask some questions as we go through this, through the online texting. And I'll start with the case. So this is a patient of mine that I saw at the age of 41 with an incidental renal mass in 2010. It was an 8-centimeter mass, and underwent a right radical nephrectomy in 2010. It was very central. We're unable to do a partial nephrectomy. And the final pathology showed a 6-centimeter grade 3 out of 4 sinus invasion PT3A clear cell carcinoma. So by the classification, PT3A would be into the sinus, and so that would be classified as high risk for recurrence. So we did offer an adjuvant trial. We've had a great session today on adjuvant therapy, and this is again a space for the urologist to counsel patients about the risk for recurrence at a PT3A, who counsel about a 50% chance of that cancer coming back at 5 years. So pretty significant, and we had some discussion previously that some urologists would counsel that you're at high risk for recurrence, which is a bit nebulous. I think that giving the numbers is important for patients, and 50% is quite high. We did offer enrollment in the PROTECT trial, which is an adjuvant pazopanib trial, and as we saw today from the data, that this was unfortunately a negative trial. He declined this trial, so probably smart call. And the CT scan of the chest, abdomen, pelvis in 2013, we followed him for 3 years, was all clear. And then he failed to show up for any follow-up appointments, unfortunately. And then in 2015, presented to his family doctor with a new cough, and a chest x-ray and subsequent CT scan showed some left hilar lymphadenopathy. So this is now 5 years post-nephrectomy. There was also 3 large lymph nodes, 2.3 centimeters, 2.4 centimeters, 1.3 centimeters, in the hilar area, a new 1.9 centimeter left lower lobe lung nodule, and a 1.8 centimeter left adrenal nodule. Now, interestingly, this was 5 years after surgery, and many of us as urologists, according to the CUA guidelines, would have discharged this patient to the family doctor. We're amending that so those patients that are at high risk for recurrence, that you consider follow-up every 2 years up until 10 years for high risk. So those guidelines will be presented at the CUA meeting on the Tuesday, and I hope you'll attend those. Dr. Wes Kassouf will be presenting those updated guidelines to give some guidance for our urologists. And and medical oncology community about how long to follow these patients. And certainly high risk, we would recommend follow beyond the 5-year benchmark. This is a view of the CAT scan. We put an arrow there so you know where the lung nodule is. So that's the lung nodule, and this was in 2015. And so you can see that pretty clearly, and also some pyelolymphadenopathy. And this is real-time CT scans. If you look at the 2013 data on the left-hand side, 2015 data on the other side, there actually, even though the CAT scan was read as negative in 2013, there is a small nodule in the adrenal, which is read as normal. Dr. McIsaac doesn't feel that way. Do you think it's normal or no?
In retrospect, looking back, pretty small.
You would have said that normal too?
Yeah.
Well, you're right. It would have been read as normal. So and there is a little tiny thing there though, and it did grow. So this is where the growth is. You can see 2015, you have these hyaline lymph nodes and the lung nodule and this adrenal nodule. So he does have what appears to be metastatic disease. It was 5 years afterwards, and so there's some debate about if we would biopsy this. So we're not sure, Doctor. What would you, Dr. Levesque, would you biopsy that, or would you just put him on systemic therapy?
I would biopsy that. I mean, I think that it probably is what it is, but you never know.
I think that's true. So I agree with you, and that's what I did. It was 5 years after surgery. I thought, we're not sure what's going on here. We better biopsy this and get some tissue diagnosis. And it was positive for a metastatic RCC. He had a good performance status. At this point, he is now 45-ish, 46-ish. IMBC criteria, normal CBC, normal calcium. Again, the IMBC, for those that recollect this, it's a CBC component, platelets, neutrophils, and hemoglobin, calcium. Those are all normal. Performance status was excellent, and time to diagnosis was 5 years. So he had none of the IMBC criteria, so it was 0. Good risk IMBC. And at that time, we were offering a clinical trial. So in fact, he was enrolled in the Bev-Atezo phase 3 first-line trial. We've got a great summary of the trial, and we were taking care of this patient through the trial. And he was randomized to the Bev-Atezo in January of 2016. He had some minimal toxicity. He did have some slight hypertension, which mimics the study data that we just heard so eloquently. But otherwise did very well with minimal side effects on this, and did quite stable disease. He did receive the dosing of 1,200 milligrams of Atezo and 50 milligrams per kilograms of Bev, and was able to tolerate quite well with some hypertension. As for the study protocol, we did do a CT scan every 8 weeks. I'm going to show you some pictures, but this is what happened during the course of his time on the trial. In February of 2016, the left lung nodule decreased from 1.9 to 1.5, so he had some regression. The hyaline lymph nodes were stable, but the adrenal nodule went from 1.6 to 2. So Ian Brown, I'm going to ask you some questions about this. So now he had some regression of the lung nodule, stable hyaline lymph nodes, and adrenal nodule is larger. So I thought, that's a stable disease, mixed response. We'll keep an eye on it. As per the study protocol, less than 10% progression, so they were fine to keep him on it. April 2016, a few months later, left lung nodule is stable, hyaline lymph node is stable, adrenal nodule is bigger, 2 to 2.2 centimeters, no new disease. A few months later, again, everything is stable except for the adrenal nodule is bigger at 3 centimeters now. And it appears to be continuously growing in July of 2016 again. More further regression of his lung disease, but the adrenal nodule is even larger, just by a few millimeters. So now it jumped at September 2016, been on trial now for about 8 months. And left adrenal nodule has gone to 5.4 centimeters. I'll show you. Is the adrenal nodule functional? High and nil. Ben Chu. Hi, Ben. I did a metabolic workup, and it was negative. Thank you for asking. That's a great question. So this is the picture here, and you can see in real time again, October 2016. Those are the hyaline lymph nodes on the CT on the left. On the right, you can see the adrenal nodule is really quite a bit larger. Even Dr. McIsaac can see that it's bigger than the previous one. So we can see that that's quite a bit larger. So now the question is, what are we going to do? Dr. Brown, what would you do? That's a good option, and in fact, I didn't even suggest that option. These are the options I put up there, but as I revise this case, I'll put in biopsy in there, because that's a great idea. I felt that it was metabolically inactive. It does have metastatic RCC. I felt that it has to be metastatic, but I think a biopsy is a very reasonable choice. Let's assume that the biopsy is negative. In fact, I didn't biopsy it. but let's assume the biopsy was negative. I think these are the options now. We have Dr. Luca here as a radiation oncologist, so maybe he can see whether he would radiate this. I'm sure he would. Oligoprogressive adrenal metastases. Would the surgeons take this out, or should we just say he's got progressive disease and go to next line therapy?
I guess I would go back and go with what Ian said. You've got a mixed response, and while with tumors you get mixed response, flags start going up. So I would actually push for some sort of pathology.
I think it's a reasonable suggestion for sure.
And certainly before giving RAS, I'd push for that.
Yeah, right. Would anybody radiate this besides Dr. Luca?
No radiation.
You would radiate it? What would you do, Dr. Song?
Well, it's an adrenal mass, right? So I'm wondering if there are roles for an MRI as well. You've done biochemistry, but and biopsy should be consideration as well. But I would do an MRI to make sure there's no enhancement on T2. But just
very reasonable suggestion as well. Dr. North, what would you do? Well, you already know the answer, but go ahead.
Yeah, well, I just wanted to follow up by commenting that the biopsy is very reasonable. This guy was 41 years old when he was diagnosed. He could be VHL. We don't know anything about his family history. It's a very reasonable question to take a look at other pathologies. And, in our center, we would love to be able to push for more role for radiotherapy in these cases as a localized therapy. So whether it be SBRT or some type of localized therapy. And in the context of being on first-line TKIs, there are trials ongoing looking at that question, which we should be supporting.
So for the people on the WebEx, they can't hear the audience questions. And just to reiterate, Dr. Luca said he may consider radiation because that's what he does, but he'd want a biopsy first. Dr. Brown mentioned a biopsy. Dr. North mentioned a biopsy. In fact, I didn't biopsy it, and this was reviewed by the study monitors. I felt that because it's metabolically inactive, which is what Dr. Chu suggested, that this has got to be a malignancy, whether it's a separate malignancy or an adrenal metastases. Either way, I felt this was progressive and the rest of the disease had regressed. And so, in fact, I elected to just remove it because that's what I do. So we proceeded with a laparoscopic left adrenalectomy to remove this lesion. But I think your points are all well taken. Again, this is a real-life case, and in my practice, and I think those points are well made. I did a big biopsy. I did a laparoscopic biopsy. So we did a laparoscopic left adrenalectomy for oligoprogression in October 2016. It was, luckily, in my case, I guess, a metastatic clear cell carcinoma, 7 centimeters. So it was metastases there. And because he did have oligoprogression, he had to come out of the trial, even though I felt that with the metastatectomy, the rest of the disease had regressed, and he could probably stay on it. I think in real-life practice, we may consider keeping him on therapy with the metastatectomy. Again, a big plug that these patients should be seen by the multidisciplinary team, people like Dr. North, who are very capable, would probably get a surgical opinion or a radiation oncology opinion during the course of the patient's disease. And I think it's very important to consider surgical options, radiotherapy options during the course of the patient's disease for metastatic RCC. And in this case, I think it benefited this patient. And I think if he was outside of trial, we would probably carry on with a approved atezo-bev. In this case, because of the trial criteria, he came out. And the postoperative CT scan showed that the left lung mass grew and off of therapy, and the high level lymph nodes were stable. So because it was a clinical trial, we were able to get funding for sunitinib for him for 50 milligrams. And we put him on 2 weeks on, 1 week off. We can have some discussion for those that want about the schedule for sunitinib, dose escalation, dose de-escalation, 4 weeks on, 2 weeks off. Many of us put on sunitinib 2 weeks on, 1 week off, so that's what I elected to do. And the CT scan in February showed stable disease, but in April, unfortunately, developed some new bone metastases and received some palliative radiation, and now was a year, about a little less than a year on atezo-bev, and a little less than 6 months on sunitinib, and then unfortunately deteriorated and chose palliation. This is sorry, there's a question? How about surgery to the oligoprogressive adrenal mass? I think it's a great suggestion, and that's what I did. It's a great idea. Dr. Ibarra, yeah? Is a PET scan helpful? I mean, I think we had a good discussion at one of the meetings that PET scanning is not really that useful for kidney cancer, but I think it's provocative and investigational. In my practice, I don't use a lot of PET scanning. I'm not sure if you have any feedback on that.
No, the problem with PET scanning is they're so variably positive or negative that the positive and negative predictive value doesn't help you. And I think in this case, whether it's PET positive or negative, you're going to take it out surgically or you're going to biopsy it. And you're probably just wasting time trying to get a PET authorized for a non-clinically indicated scenario.
Dr. Song?
I'm wondering, when this lung lesion grew, I kind of lost track of how many that we had. Was that just kind of a solitary lesion? Would there be a role for excising the lung?
So if it wasn't for the 3 hylar lymph nodes, I would have done that for sure. That's a great suggestion. Again, and the other option it would be if I was always planning on SBRT at some point because he didn't have a lot of disease at the time. He had those 3 hylar lymph nodes, and then he had that lung lesion, and the adrenal was out. So that's actually pretty small volume disease, but he progressed quite fairly soon on sunitinib with the bone metastases. At this point, there's no role other than palliative radiation for bone pain. But that would have been a good option. So this is the CT scan of the post-adrenalectomy showing that it's gone. And luckily, he had another contralateral adrenal. You can see there, I didn't put an arrow to it, but you can see on the screen that the contralateral adrenal was spared at the time of his nephrectomy. And just to plug again that the guidelines from many organizations suggest that the adrenal gland is not involved by the tumor, and there's no mass lesion in the adrenal gland. You should not take the adrenal gland out with a radical nephrectomy, and this is the kind of case where it benefited the patient for a period of time to have a contralateral adrenal still in place. So we have an organization called the Kidney Cancer Research Network of Canada, and it's a group of medical oncologists, urological oncologists, urologists, and radiation oncologists that meet every year to look at consensus statements to guide our community in Canada how to treat patients for various diseases and various kidney diseases, kidney cancer diseases. Dr. Rendon has developed the cytoreductive nephrectomy guideline, and we have an annual meeting looking at advanced disease in terms of guidelines that are tailored to a Canadian audience. So we just had this in a few months ago, and Dr. Denise Soulier is a main author who's in the process of writing this. Dr. North was a previous main author, and he's passed on the reins. And part of this consensus that we've met a few months ago, we've endorsed Ipi-Nivo as an option for intermediate and poor risk patients based upon the fantastic data that we've seen. This is going to be a new standard of care. Somebody that comes through the door with metastatic RCC after nephrectomy, possibility for metastatectomy, and if they're intermediate and poor risk based upon those IMDC criteria, they'll go on probably Ipi-Nivo once we have approval shortly. However, for good risk patients, again, we have VEGFR targeted therapy. There'll still be a role for pazopanib or sunitinib or perhaps cabozantinib based upon the CABO-SUN study. And so there'll still be a role for the good risk patients. And the data on atezo-bev, again, looks very exciting based upon the presentation today, but still needs some maturity, and we need to have some long-term data, further-term data about recommendation as first-line therapy. But based upon the toxicity profile being so favorable, including for this patient who did so well, it seems like a very good option potentially for the future. These are going to be the guidelines that we're going to suggest when you see these patients that, and again, this is important for urologists to know as well as radiation oncologists, because you can also have a brief discussion with your patient before you send them on to medical oncology, saying this is what they may talk to you about for intermediate poor prognosis. And even Dr. Brown can go over the IMDC criteria. He already knows them by heart now. He'll say, you have none of those or you're intermediate poor or favorable. And these are the suggestions that if you have intermediate poor, Nivo-Ipi, sunitinib, pazopanib, or cabozantinib, based upon the phase 2 trial. Cabozantinib was a phase 2 CABO-SUN trial, 80 patients per arm, but looks like reasonably good data to suggest it in this first-line therapy for intermediate poor. Favorable, again, sunitinib, pazopanib, or cabozantinib, and we'll see what happens with atezo-bev in the future. And I have less than 10 minutes left, I was told, so I'm going to speed through this. Second-line therapy, clinical trials for sure, and first and second-line therapy. And once they progressed on the previous algorithm, then we have an algorithm that we're suggesting to move forward. And this is our second-line algorithm that looks complex, but basically depends on what you receive in first line. So if you've got an anti-PD-1, PD-L1, then you can offer a TKI-based therapy, axitinib, which is approved, cabozantinib, based upon the METEOR study, sunitinib, and pazopanib, which are already good options, but have some efficacy post anti-PD-1, PD-L1. Post VEGF targeted therapy, any of those VEGF inhibitors, we have some standard already for those. And these are the standards. The plus signs mean that these are preferred recommendations. Cabozantinib or nivolumab, which have phase 3 data based upon METEOR, and the Nivo data, which is very strong data showing that these drugs have good efficacy post VEGF targeted therapy in the middle column. Axitinib still has a role. Everolimus we put in here, but I would caution you in Ontario using everolimus because if you use everolimus, you cannot get funding for nivolumab after that. We've had that barrier in Ontario, so perhaps everolimus should be used as a very last resort. And lenvatinib everolimus has some great data as well, post VEGF targeted therapy, showing this also has a place in second-line therapy. And post the last column, post PD-1, PD-L1, and VEGF targeted therapy, cabozantinib, axitinib, len-ev, and potentially chemotherapy we thought we put in there for completeness sake. So just to summarize as the last slide, first-line immunotherapy for metastatic RCC, the KCRNC has endorsed for guidance using IPI and Nivo as an option for intermediate and poor risk, VEGF targeted therapy for good risk, and atezo-bev needs some maturity but looks exciting as a potential first-line option once we have some more data with low toxicity and potential option. And I want to conclude and thank you very much for your time. There's another question. What centers have approval for these trials? Well, Dr. Barra, most centers have approval for these trials. So all the major cancer centers, including here in Hamilton, the Juravinski, as well as all the other major cancer centers have approval for these trials. So we're happy to see these patients. Can these patients be referred to such centers? Yes, we would love to see these patients for these trials, and so bring them on. That'd be great. Any other questions and discussion? That'd be great, Dr. Song.
So is this now going to be an algorithm guideline? So that there's no role for, this is adjuvant IO therapy as first line doing Nivo and EP. And there's no role for neoadjuvant in terms of the nephrectomy.
So that's a great question. Dr. Song has asked a question about is there a role for adjuvant and neoadjuvant. So these are treatment-based algorithms for established metastatic disease. So this wouldn't be adjuvant or neoadjuvant. This would be somebody that comes into your practice with metastatic disease. So then with metastases, you would do your appropriate surgical management and then send off to the medical oncologist for treatment with ipi-nivo if they have good intermediate risk, or TKI-based therapy if they have favorable risk. And so that would not be adjuvant or neoadjuvant. But if you do the nephrectomy for non-metastatic disease and you have a very advanced cancer, PT3, right now we recommend enrollment in an adjuvant IO trial, which are all being offered at all the major cancer centers in Canada. I think that's really the key to enroll them in those trials because there may be a role for that.
But the reason I asked is that at one time there was some discussion whether you could downstage the tumor by giving the chemo up front before the nephrectomy. So I'm wondering if there's no longer any role for that, or is that still used case by case?
That's used for case by case. So I think I presented some cases at a previous meeting, and I think the role for neoadjuvant or pre-surgical therapy before cytoreductive nephrectomy or neoadjuvant therapy before localized disease is really individualized for solitary kidneys, bilateral tumors, or special situations. Right now, it's not standard. I think if you have a patient that comes through your door, as per the cytoreductive nephrectomy guidelines, we'd recommend you do a cytoreductive nephrectomy and then send them to your medical oncology colleague for first line therapy. A plug for the Prosper trial. Again, we have this neoadjuvant nivolumab trial which is a cooperative group trial through the CCTG that we're going to roll out across Canada, and that's a great collaborative opportunity between urologists and medical oncologists to give two doses of Nivo before the cytoreductive nephrectomy, and that's for non-metastatic disease but high risk. And I think that's a good opportunity to be involved in this.
I know I'm kind of pedantic about this, so I'm going to kind of put it out there. If we're saying that this is for metastatic disease, then the term neoadjuvant and adjuvant is a wrong term.
100%.
It's
yep.
definitive.
So I tried to clarify that. So if it's before cytoreductive nephrectomy, it's called pre-surgical therapy,
Correct.
Or just therapy before surgery. If it's with curative intent, then it's neoadjuvant.
Correct. So
that's for all disease types.
Yeah, exactly.
Thank you for keeping me straight. Thank you. On that happy note, we're going to call it a night. Thank you very much for attending, and have a great dinner. And thank you for signing in online. Thank you so much. 1 minute to spare.